think is my screen visible?
Yes, it is.
Awesome. Okay. Thank you so much, everyone. This is also thank you so much, Sonali, for the opportunity to present. I've recently started working on a more academically aligned way of working. So this is one of my first presentations outside the lab about you know about my research work. So I'm a little nervous about presenting my work, but I hope some of the work is interesting to you, and I invite any feedback and discussion afterwards. Now, the topic of I've just made it full screen. This is visible, right?
That's
Awesome.
perfect.
Okay, cool. So we today's topic, one of the first papers I'm working on is using unstructured patient notes or visit notes to infer clinical guidance trees for doctors. Now, to introduce this, if you're not familiar with the medical process, slightly, I'll give a brief overview. Let's say I have a condition like meningioma, which is a very common benign brain tumor. It's one of the most common benign brain tumors. So let's say I have this condition and I walk into a doctor's office. From the get-go, from the nursing staff to the doctor, anyone who sees me is going to write a few notes. Okay. And when it comes to, let's say that I have done my MRI and it turns out that I have this tumor, the radiologist says that, such and such tumor has turned up in some part of my brain, and whatever it is of this size and so on. Now, to treat me, there is a certain decision tree, or there's a certain flow chart in published popularly in the medical literature. The doctor who will see me, they must have learnt this at school, at medical school, how to treat a meningioma patient. Okay, and let's say this hypothetically, this clinical guidance tree was first published, or the latest edition was in 2015. Now, since 2015, so what does this tree say? It says, look, if the patient is above 60, maybe don't prefer surgery. If the patient is female, then certain drugs don't work on them. So maybe apply such and such methodology to counteract, or some, there are specific pathways for different demographics and different conditions and locations for meningioma and so on. So now, when the sorry, when the clinical guidance tree itself, the tree diagram is first published, since then there must have there are sometimes new drugs approved for the same same condition. Now these drugs may work specifically well on certain kinds of patients, may not work on some others. There might be some other insights during the course of treatment. A neurosurgeon might recognize a certain pattern among people, saying, such and such ethnicity. If you're South Asian, you're more likely to respond better to this kind of treatment, but not so much if you're Latin American. So, right, so we'll not prefer this and so on. Now, if a neurosurgeon discovers this pattern and starts applying slightly different treatment pathways over the course of the treatment, this insight is intuitively it. So I wanted to visualize, there is this clinical guidance tree that comes from literature. This doctor is essentially implicitly forking it or creating a copy of it in their head and modifying it, saying, I'm just going to change this part of it. Right now there is this updated version of this tree that they use, right? And now think about all the hundreds and thousands of neurosurgeons or doctors that we have for this specific condition. They are going to have their own copies. Now, when do these copies talk to each other to form this super smart, more optimized tree? Well, the only process that we have right now is that the doctor has to also publish this as a research paper, and they have to go to conferences, and people also have to, this information again has to be propagated back to everyone else, right? So this kind of inefficient. So we thought that using AI, can we first, so one of the problems that we tried solving for is how do we know what is this so-called copy of this decision tree in their head, right? Because it's never really explicitly written down on paper. The doctor doesn't, you know, publish this clinical guidance tree. So it's implicit, it's intuitive. So can we use their patient notes to infer what's happening inside their head? Can we make the implicit explicit? And then can we start, using some kind of federation algorithms? Can we put them together and, distribute this latest trees? Can we share this wisdom faster and on a continual basis? Right. And I mean, I'll tell you why we are doing this whole, back and forth, why infer and so on. We have seen papers like this one recently published. In an experiment, they gave doctors ChatGPT, okay, and they compared how regular doctors without ChatGPT performed on in diagnosing certain illnesses, doctors with ChatGPT, how they performed, and ChatGPT on its own. Now, it turns out that the model itself, ChatGPT, was better on its own than doctors who used ChatGPT. And that is surprising. It actually outperformed doctors using ChatGPT for diagnosis, right? Which is okay, which is great for progress and so on. But the doctor still has to administer the actual treatment, and it becomes difficult to trust the output of the model if there is no interpretability in how it has arrived at this conclusion. Okay, so we want to sort of bridge this gap of superb capability of these new language models, and so we want to bridge what these models can do and add some interpretability to what they're doing and why they think this is the case, right? And that's why we thought that the intermediate representation for us to communicate is these clinical guidance trees, right? That's the data structure that we thought is best for us to communicate in an interpretable form. And therefore we thought that, training better decision trees or clinical guidance trees is the way to go. We have seen other papers, and so again, this paper by Binbinli et al. It talks about, so they've created a repository, a knowledge base of 1,202 decision trees from medical literature. Now, again, the problem is that the medical literature trees, they're rarely ever put in practice. I mean, after a certain point, as I said, in practice, the trees evolve. They have people have doctors have newer versions of these trees in their heads. So while this is good, we would want latest trees to be continually updated to this LLM that provides treatment pathways and so on. So we are thinking of like a more slightly solving the data problem that we are facing when talking, when training LLMs or other models to do clinical decision making for us. Okay. So the first thing that we said is, like, we don't want any kind of semantic factoring. We don't want any kind of massaging needed to the data. We want to be able to take um, the data as it is generated, as it is produced at the hospital, at the clinic, so that there's no additional work. And this was previously not possible. About a couple of years ago, till about a couple of years ago, NLP wasn't exactly working because it required a lot of specialized techniques to make language processing tasks happen, and a lot of those have been solved for in a very generalized manner. And that's why these new LLMs have enabled, or they've made this possible. It was not previously possible, so we thought this is an exciting opportunity. We update these. So the idea of this current work that we're doing is to first only infer, only to only take down the copy, the implicit copy in the head of the doctor, and not train better clinical decision making or clinical guidance trees. that is something that we would like to reach, but we're currently still working on the data formats and an accurate interpretation of the clinical notes. Okay, so the scope of what we are doing is not to train better versions of the clinical guidance tree. It is to ensure that we are accurately at least putting the implicit copies down into the real world, right? Now, the eventual goal is to be able to train better clinical decision trees, and let me just see. Yeah, I mean, so it is to first convert past data into these decision trees, and then for each given case, that we want to enable tools that gives doctors the ability to talk about the current case. So let's say there's 20 possible decision points in a meningioma patient's journey. We want to be able to be at point 12 for a certain patient and get an answer or a probability distribution for which pathway will yield favorable outcome. That is the eventual goal for what we're trying here. Right. Now, how we did this, we've run a few baseline experiments on this. What we did is to first generate patient profiles like age, sex, blood type, profession, so on and so forth. Then we add medical history and status. For example, if the patient has any comorbidities, if at all, meningioma details. So we specifically focused on meningioma because it's a long-term condition. It can span the treatment, and the experience of the patient can span over years, decades sometimes. A lot of times, since it's benign, it is most of the times it's benign. So it doesn't end up killing the patient. The patient tends to live their natural course of life, the natural span of life, but with significant modifications to their lifestyle based on whether they've had surgery or radiation and so on. So this is long term, but it's still very localized. Having meningioma doesn't necessarily affect other aspects of your health. To give you a counter example, diabetes is a very complex disease. It adds complexity to every other aspect of your health. So we wanted something that is local yet long term. So the scope of the disease itself remains quite local, but it's still a long term condition. So we thought that meningioma is a good target for research like this. Now, so we add tumor details, size, location, and so on. The profiles are based on observed demographics for meningioma. For example, the prevalence is much higher in females. It's about 3 to 1, 3 is to 1 in females to males. So, and also, I mean, there's some very interesting factors like pregnancy is expected to make the meningioma progress much faster, right? So things like these we've taken into account when creating these virtual patient profiles. So we created these patient profiles first, right? And then we said, look, there is this patient 001 that has this medical history. They're aged this, they're male or female, whatever it is. They have meningioma, which is in XYZ cavity, wherever it is. Given this medical history, we've virtually gotten two AI agents to treat this patient. Okay, to create synthetic data, to create synthetic clinical notes or patient notes, we've gotten these virtual people treated by these virtual doctors. So each profile is virtually treated by two kinds of doctor agents. One is an aggressive doctor agent, which who prefers things like radiation or surgery, very trigger happy with surgery, will order extensive imaging very quickly and so on. And the second, the conservative treatment agent or doctor agent is more inclined towards suggesting wait and watch approaches, periodic scans, very less likely to intervene, and so on. Yet, in certain cases, they do exhibit opposite behaviors. These are all LLMs, by the way. These are agents talking to each other. The treatment, how do say, how do you say this is being treated? So we generate 10 years worth of clinical notes one by one. And that's how this virtual virtual treatment happens, right? How whether there was a recurrence or not. So we've modeled chances of recurrence as well, and so we've simulated this longitudinal journey of the patient. As if some of you are from the work within medical research, medical data science especially, you would know that getting longitudinal data is extremely difficult. It's very, very limited data. Oftentimes, often the data is not in a format that format in the sense like it's not extensive enough, it's not detailed enough. Very limited ICU data and so on. I've come across open data sets are very hard to come by. So to get around this problem, I said we'll create synthetic data that at least resembles the shape of real world data. Although there is no ground truth to it, the form of the data, the shape of the data can be very, very grounded in real world scenarios. We can give it some patient notes. I used some of my patient notes, although I don't have meningioma. I had to undergo a surgery in the US. And so I took the formats that they used during my surgery at Beth Israel, and then used that to ground the clinical notes that the models generated. Okay, so we have gotten these 10-year longitudinal patient notes in place. This is how we have now virtually treated 100 patients. We've passed down to each patient gets treated by both doctors. And so therefore we have 200 virtually treated cases. Um, and then we construct this decision tree. And now to give you an idea of what we're doing here is, so if you can see, we've created this flowchart, this that resembles a very, very simplified version of common meningioma treatment pathways. Okay, so when upon initial MRI, if there is suspected meningioma, whether to treat the patient as symptomatic or asymptomatic. Okay, so then there's a certain waterfall on the other end. The tree branches in two ways. Now there is another point where you ask whether the patient needs surgery versus radiation. Right now, we've created a very, very simplistic diagram. You can see when it comes to the actual post-surgery management, we have only taken grade one cases for our for the purpose of our first paper. We only generated grade one cases, very few grade two cases, because it again complicates. The tree needs to be interpretable. The model is still not very good at giving a very detailed this thing probabilities for each point. So we kept it as simplistic as possible. This is an oversimplification. We have talked to a few radiologists. We would want to have an entirely accurate real world model for this, but it's kind of we're getting there slowly and gradually. Okay, so now we've used this tree as a guidance, as a grounding mechanism for all the virtual treatments that have happened. Okay, so the clinical notes are grounded with this tree in mind, so that it it doesn't emit or output entirely diverging pathways where it introduces nodes in the tree diagram that did not exist, right? Like the doctor isn't now saying that the final decision is that the patient is going to go for walks regularly. Like, I mean, sure, so it wouldn't give such ridiculous outputs, but we just wanted to restrict we just wanted to know if this virtual doctor treated 10 patients, what is the probability that the next patient is going to be considered a surgical candidate. Okay, so we were just trying to derive probabilities for each decision point in this exercise first. Right. I mean, at the end, if we have time, I'd like to show you a live demo. So we have this website deployed where you can actually browse some of these virtual patients. You can go and read the clinical notes. You can read their demographics, and then so you can select a bunch of them, say 5, 10, whatever it is, and have them have the model infer these decision tree probabilities. Okay. So what that does is, given these specific 5 cases, the aggressive doctor tended to, let's say, sorry, tended to prefer complete resection 70% of the time, and 30% of the time it used to be incomplete, right? But let's say, if at all the what do you call it? The conservative doctor went for surgery, then they would also prefer complete resection. But if you see at the top, they did not prefer surgery to begin with. Only 40% of the patients treated by this conservative doctor ended up on the surgery table. Okay, and the model changes, so you can dynamically give it more or less fewer patients, and it will change the probabilities because this is based on what has been observed in the past, right? So, so now think about it. You as a patient walking into either of these doctors' offices could quite significantly change the outcome for your treatment. And that's the whole point. We're trying to bridge this gap. There's no specific reason why the aggressive doctor is better or the conservative doctor is better. We have taken two archetypes here, but the point is that none of them are universally the best. Okay, and so we're trying to create, and they have their own wisdom. We want to create mechanisms that can bridge this gap and have both of them deliver favorable outcomes. Let's say you were a 60-year-old female, maybe you could have had a very favorable outcome with the aggressive treatment pathway, or with a conservative pathway. We just want to observe for now how it turns out, and then maybe, as I said in the subsequent papers, we would like to explore, can we train better clinical guidance trees and then propagate them faster in the medical networks? Right. This is so I just want to sort of have you look under the hood a little bit. This is the sample clinical note that we've generated. The patient ID. I mean, this is redacted, but it's generated by an LLM. So there's no real patient behind this. But demographics 50 blood type B, whatever it is. Initial visit, it says presenting complaint, progressive neurological symptoms, headaches, and so on. Imaging findings at this MRI reveals 4.2 FALX or parasagittal meningioma, grade 2, and so on. So this is serious, whatever. Right? Given patient's history of childhood radiation exposure and current oh yeah, so we've simulated that some people also have childhood radiation exposure and so on. Careful consideration is needed. And then the doctor writes the plan, and then you can see that the first visit is in March 2018, and then the follow-up is in June. And so you'll see this note actually runs very long. This runs for 10 years, right? So not all of them are as extensive as this. There's sometimes just regular check, MRI, no recurrence observed. So for a few years that's all it produces, and then 3 years later it says there is some, the MRI shows some growth and so on. So again, I don't know, I mean, afterwards, if you want, there is a link where you can actually explore these clinical notes for yourself. You can visit and see how the patients did over the course of years. It's all published, and just to just to see how this virtual treatment happened and so on. Now, some of these code snippets, again, if how I know this sounds looks very technical if you're not you know familiar with coding, but this is just very simple stuff that we accounted for when generating these virtual patients, such as meningioma grade, whether there's obesity or not, because again, that is a factor, whether the patient is pregnant or not, whether they're oh sorry, whether they're a knowledge worker or not. Because a lot of times we have observed that neurosurgery, this is a consideration. They ask you what your occupation is, and that changes how they treat. It sounds very odd, and it sounds like, a little bit iffy. However, a more aggressive treatment could ensure higher survival of the patient, but if it renders them unable to complete their job, it also has an effect on their livelihood. So it's a very gray sort of calculation, but this is a factor that's been observed. So we just kept that, whether the person is a knowledge worker or not, whether the person's profession requires olfactory senses to be intact. For example, maybe some neurosurgery could impact or impede the olfactory senses. And if the patient is, let's say, a chef, their livelihood depends on retaining their sense of smell and taste. that is also maybe like that is also a factor. So do you then not prefer surgery if a complete resection would render the like would impact if you know that it would impact the olfactory senses. So we've created a very comprehensive profile of the patient. As you can see, we've assigned specific distribution to whether the patient is going to be um, obese or not, which grade. So we've said 90% of the times it's WHO grade 1 meningioma, and only 10% cases are grade 2. Right. So we've kept the demographics in our control. You can have these knobs and dials in your hand. Now, even for tumor details, we have preserved the prevalence as observed in the real world. So let's say parasagittal meningioma is the most common. Foramen magnum locate like these are the locations where your tumor could be, and we've kept the prevalence of those like the appearance probabilities consistent with what's observed in the real world. So we've tried to have a very high resolution simulation as much as possible, right? So the size distribution as well and so on. So we add these two together, profile and your tumor details, right? And then we generate this text medical details. So we put this entire patient profile into the model, and then we say uh, we ask it to generate realistic symptoms and medical history that ends up in the patient having this kind of meningioma. Okay. So here is where it adds comorbidities and things like that. The model decides that, oh, this patient is obese and has whatever their age is this much and so on. So therefore they're likely to have diabetes. So this is where that randomness, that chaos, that noise is added, where the presenting symptom. So the medical history, the model has outputted in some cases that they have diabetes, or they have type 2 diabetes diagnosed 3 years ago and so on. Very detailed sometimes. So we generate this medical. So we had earlier profile who the patient is, and now this is medical history, which is what the patient has experienced, right? In terms of medical this thing. These are the prompts we used for aggressive and conservative doctors. So first one is, as a neurosurgeon favoring proactive intervention, write a detailed clinical note for the following patient. When then this is the patient context is a variable where we insert essentially the medical history and the profile. Okay, that's a placeholder. And then focus on early intervention strategies, comprehensive imaging protocols, aggressive treatment options, include specific recommendations for frequent monitoring, potential surgical intervention, and so on. Right. So this doctor is going to be very trigger happy. The conservative doctor, on the other hand, is focus on watchful waiting approach, minimal intervention strategies, quality of life preservation, and so on and so forth. Right, and you'll see how it diverges. How they end up having very different outcomes. Um, Now, so what we do is get when we are so we have generated using these prompts, we have gotten this patient virtually treated, right? We have 10 years worth of longitudinal clinical notes now. Now, taking an aggregate of whatever 5, 8, 10, which whatever patients they've so far treated, we want to know the probability for them to, say, attempt a complete resection, the probability of that doctor agent to attempt a surgery on a patient, right, based on the observed data. So this is the prompt to that we use to infer these probabilities. This is all again LLM. We did not do any. So this is it's important to highlight that we've used LLMs to also infer the probabilities because it allows us to have a very flexible decision tree as well. The clinical guidance tree could be swapped out right here, right? This is a string, but I could actually make this a variable. This doesn't need to be hard coded. So as long as soon as I change the decision tree above in my snippet in my notebook, the prompt to infer the decision tree also dynamically changes, and therefore we have a much more flexible way of working with these patient notes, and it allows for newer possibilities very fast. We for the scope of the paper, we kept it very simple and very limited, but this allows for a very flexible approach to to account for. So, for example, if the tree that I showed you, the flowchart, if it changes tomorrow very suddenly, I don't have to write a lot of custom code to then enable infer the probabilities and the additional pathways that they might have, right? So it's just as simple as updating the updating this string, or maybe even swapping out uh, the text. So it's as easy as that for us. Now the benefits, and I mean, so given this, there are certain benefits, there are certain very interesting things that we found, but there's obviously certain limitations. So I'd just like to mention them very quickly. So the benefits are that evolving decision trees. So you could have evolving decision trees as newer cases appear. Right now, the point is not just on the past data, but every single patient that you encounter is going to add to this wisdom. It's going to see how the treatment pathway, which one was opted for, and it changes the probabilities for each of these probabilities for each of the nodes or each of the decision points. And therefore, you have this continually updated version of this tree that we began with, right? And so it also, if it is always explicitly being inferred on an ongoing basis, you also have the opportunity to then federate them and have a super tree, have a super collaborated tree. So this enables transfer of wisdom from one doctor to another, one hospital to another, one region to another, right? To give you a small example, hypothetical example, let's say that a doctor at Brigham Institute in Boston figures out that a certain drug that's come out, which is not used for meningioma specifically, but if used on meningioma patients, let's say above 45 female, the progress of the progression of the disease is controlled very well. If they discover this, how is this wisdom being shared? How is someone at you know how is someone in California benefiting from this? Let alone, like, forget California. Even if there's not a regular contact, even someone like a doctor at Beth Israel would also not be able to, within the same city, would not be able to leverage this new wisdom, right? So we want to allow transfer, a much more fluid transfer of wisdom through a project like this. Coming to the limitations, the most major limitation for what you have seen right now is that the data is synthetic, right? And limitation in the sense that it's not a technical limitation, it's just that the we can't have real world assertions based on this virtual treatment that we have done. We can easily swap out real world data with the synthetic data and have decision trees that are actually observed in the real world, right? Like, we don't know when the model decides, let's say during the course of the treatment, sometimes the model says the patient had recurrence after a surgery, right? Now, whether that would have actually happened or not, and questions like those are, there's no literal truth, there's no ground truth backing this. However, it's based on averages. Since the model is also trained on a large amount of data, it checks for how likely it is for someone with that specific condition, with that this thing, body structure and so on, to have a recurrence in the meningioma. So the limitation is that there's no real world truth or grounding to this. However, it can be very easily swapped out. The data that we have fed can easily be swapped out. The inference code still stands the same, the one that derives the decision tree. The patient generation and the virtual nodes and all of that, it's just to be able to get around the data problem, right? The cold start problem, so to say. So they're kind of like two projects put together. One was to generate these nodes, and then how do you take these nodes, and then so you can just remove this virtual part of it and attach the real part, and the next stage of the pipeline still stays largely the same. right? Now, what's next is we're very excited. It's to so one way that we generated these notes is to tell the model to generate 10 years worth of notes in a single shot. Now we're going to try node by node, which means that we have independent calls made to the LLM, and we want to see if it changes the outcomes or changes how it outputs, because of how LLMs work. When it starts generating the first text, but it knows that it needs to generate 10 years worth of data, some of the the pathways seems very nicely, it looks very synthetic. So the conclusion was already decided. It looks like the conclusion was already decided, and then it kind of backfilled how to arrive at that history. Okay, so based on how, I mean, this is not exact, but we just want to see if you go node by node, if introduce some chaos in between the treatment, what happens. Second is assemble a team of like a medical staff agent group, so we don't just say it's not just going to be one person. There's an entire medical staff, so right from nursing staff to radiologists to surgeons to physicians and residents and so on. So doctor agents collaboratively generate these patient notes, right, during the hospital, whether they were admitted during surgery, pre-surgery, post-surgery, anesthetists notes and so on. So they collaboratively generate these clinical notes. So to again add a better, more realistic clinical note generation mechanism. Third is clinical note to structured format conversion. This again goes back to, so the tree that we have currently used is a very simplified version of the treatment pathways. We want to have the grounding tree that we are using. We want it to be like real world, how the real world decision trees are used in practice. So we want to get to that point where we actually are using those structured clinical guidance trees. Fourth is that, to enable back propagation, to actually train better decision trees, to optimize for a certain outcome. For example, during the in our virtual treatment, sorry, we've used this metric called ECOG to test for the functioning of the patient, right? So to, let's say, can we have can we train trees to optimize for higher ECOG scores, right? Again, this is part of like how do you train the most super optimized tree to distribute among all the medical practitioners. So the live demo is here. If we have some time, I could show you how the decision trees evolve. And the GitHub code is visible on my repo, and the sample clinical notes are also. You're very welcome to take a peek and just it. I don't know. There's a certain feeling of it's eerily real world seeming. So I think it's an interesting exercise, and I encourage you to look at these notes. So that's been my talk. Thank you so much.
Thank you very much, Nilay. This was awesome. So I will post these links, or you can go ahead and do that yourself so that they're easily accessible. And I'm also happy to share the slide deck later. We are recording this talk, so we'll also post that on YouTube. I'm seeing a lot of applause. Are there questions as well? So while people are thinking, I have a question, Nilay. So
Mhm.
as these doctor agents are seeing the patient notes and they are kind of reacting to possibly modifying, are they using that information to modify clinical decision trees in their own head, like just like the real world doctors do. Are these virtual agents learning if they're treating 100 patients, when they're treating the 57th patient, have they learned from the 56 patients that they treated before that?
So for this version, they're not updating their treatment pathways. They don't. So when the doctor agent sees a new patient, they don't know that they've also seen 10 patients earlier. So we don't carry forward history across this thing. But this is a very interesting idea that we want to put in the next experiment that we do. So thanks for bringing that up. So just to show you how what the doctor agent sees at T0, right? This is what the agent sees. So the age, the demographics, the presenting symptoms, and the medical history. Right? This is all they've seen. They don't know the past, and they're only asked to treat. So when this patient was given or treated by an aggressive doctor, this is what happens, right? So progressive headaches. The first report is usually just reporting what is observed and then giving a plan. And then, over period. So the first visit is again March 15th. You can see that over here it says, oh, second surgery is scheduled. There's an urgent visit in March 2022. Maintaining they again have a second surgery, and then stable return to modified work schedule and so on. So it also, very interestingly, the model started outputting whether the patient is working again or not. Return to part-time work, return to modified work schedule, and so on. So this is all that the agent sees, and the next patient, let's say, the let's say they're treating this one, they don't know that they've treated the past one. So hope that answers your question.
Yes. And what was the outcome in terms of the conservative and the aggressive agents in the end? Like, let's say, in terms of average ECOG scores or something like that.
So, I mean, as I said, right, like there's no real grounding, like real world truth to the treatment itself. So we didn't pay a lot of attention to the outcomes so much because, again, these are virtual agents, say, describing how they think. So, I mean, for example, here the first case that I showed you, it said it they had a second surgery, right? There is no specific reason why that patient would have had a surgery. We can't ascertain the truth behind whether in the real world this patient would have had surgery or not. So therefore, I think it would be unfair to judge this virtual doctor for the virtual outcomes they've delivered. But you can see that, let's say the decision tree that wait, right? So if you can, is the, what do you call it, the tree visible here, right?
Yeah, this is better when you make it bigger.
Ah, yeah. So now you can see that 85% of the time the aggressive doctor, the red one is, so we have superimpose the probabilities. So the red one is the aggressive one, the blue one is conservative. Okay, so 85.7% of the time the patient was treated as symptomatic by the aggressive doctor, and only 37.5% of the time that the conservative doctor said this is a symptomatic case. If you can note here, the conservative doctor tends to prefer this watch and scan approach. Okay, whether to intervene on growth, only 33% of the time they say yes, I will intervene on growth. Otherwise, just scan 6 months, give medication, so on. When it comes to surgery or radiation, the if at all the patient ends up as a symptomatic consideration, then the conservative doctor says it most of the times they'll prefer radiation, and the aggressive one prefers surgery and so on. Now, these probabilities, by the way, are specifically for these patients that I've selected. Okay, so if I uh, change these cases, the probabilities are also going to be different. So these are observed and not they're not predictive, right? They just tell what the probability is. So here now I swapped out those cases, right? There are no cases where the aggressive doctor says, "I'm not going to consider you for surgery." 100% of the time, they went into that surgical versus radiation argument immediately, right? So the probabilities are dependent on they're based on the observed cases. Mhm.
Yeah, thank you. This is useful. Uh, so, are there any other questions? I know that some of our attendees are from clinical background. I'm very curious to know what you all think. Catherine?
This was really cool. Do you have a plan for trying to acquire longitudinal data, or is it just that it doesn't really exist, or is there like a paywall? Yeah, I'd love to hear more about your plans around that.
So, I mean, that's if you have some data, please give it to us because we are looking for data. We're speaking to a few doctors in the US and some in India to see if we can have some kind of um, data and wisdom exchange here, because longitudinal data it exists, okay, because we're taking patient notes. This data exists. I If I had asked for specific measurements and radiology reports and so on, it may not have existed, but patient notes definitely exist. So it's not an existence problem, but rules like, I mean, HIPAA compliance and data security and privacy rules are what largely in the US we have faced problems in acquiring data. So to be able to, and I mean, our eventual plan is to have these agents be on a local machine with things like DeepSeek. We have seen that local LLMs are, I mean, they're reaching points where you don't even need a server hosted model anymore. So the idea is to have the model hosted on the hospital servers securely so that we don't actually have to see the data. But to run experiments, we do need the initial sort of seed data. We are looking for it. If you have any leads, I would very, very much appreciate having that data. But yeah, it's also not a paywall problem. It's just that specific we 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 would need the data to be given to us from specific places.
So to add to that, Catherine, all hospitals will have data for their own patients, and they're allowed to use that data for quality improvement within their own organization. But for any kind of research purposes, then we need IRBs, or we need for very good reasons to protect our patients that or their privacy. We need to be sure that before sharing any data, there are like steps to follow, which are typically quite stringent. And getting especially data like clinical notes for research purposes is very difficult sometimes, because to make sure that those are de-identified, removing patient specific information from clinical notes can be a little tricky. So because of reasons like that, it is difficult to have longitudinal data available for research purposes. And as Nilay is saying, in the long term, there can be these federated learning models where each hospital keeps their own data, they don't share it outside, and then maybe something like their own decision trees that is built on their data, that is the piece that gets shared outside, and that is the piece that gets combined to form kind of a mega decision tree that distills knowledge from each separate organization without sharing their patient data. But as Nila is saying, just to get started, getting that data is itself somewhat difficult. We have maybe time for one final question, if there is any.
Mhm. Just to add to the this thing, right? As you very nicely put this, at the lab, this is part of the larger decentralized initiative that we have at the Camera Culture Group, and so what we say is share wisdom, not data, right? And that's the or not raw data. So that this is what we are trying, but we hope that we encounter some real world data. We're trying to work with a few doctors in India as well, because first, the benefit is that we have a lot of cases. I mean, it's not a good thing, but a lot of data exists here, right? So to have research, we have to perform research on this. We have more data that exists here. Now, whether we are able to get access to it or not is another question. But there is at least some hope that we'd be able to talk to a few hospitals here.
Thank you again, Nilay, so very much for sharing your wisdom with us. And I hope everybody enjoyed this presentation. I'm going to stop recording now, and we